Hi everyone, I hope you're having a good day today. So this video will talk about the resuscitation and care of the seriously unwell child. So the key points for today's video are: we should commence immediately. Whenever we suspect hypoxia and shock, we should commence immediately. The second point is effective resuscitation relies on a cohesive team with not only knowledge and skills but good communication and teamwork. The third point is we should consider early referral to specialized pediatric or retrieval service. So these are the main points when doing any resuscitation. Okay. So let's move on to assessment and management. So the main things we should do is, the first thing is call early for help within your hospital and to a local or retrieval service as necessary. The second thing is reactive resuscitation includes assessment and prompt management in parallel. Okay? So it should include assessment and prompt management in parallel. The third thing, early allocation of roles. Now we'll talk about the approach to assessment and management. We use the ABCDE approach. A is for airway. We look for patency and added noises. The clinical features of a distressed airway are a chest wall recession, abdominal breathing, hoarse voice, drooling, stridor, and stutter. The management is we keep the child calm, hands-off approach, the caregiver present, and distraction techniques. We optimize head position to achieve patent airway. Continue the child's adopted posture if less than 1 year, neutral position if more than 1 year old at sniffing position. We also consider suction and the simple airway maneuver, which is head tilt, chin lift, and jaw thrust. Head tilt, chin lift, and jaw thrust. We insert an oropharyngeal airway or a nasopharyngeal airway if needed, and they are contraindicated in facial or base of skull fracture. Oxygen, we provide oxygen if hypoxic and consider PEEP in upper airway obstruction. Now B, we go for B for breathing. We check chest rise and fall, SpO2, which is oxygen saturation, respiratory rate, effort of breathing, effect of breathing, accessory muscle use. So the clinical features of a distressed breathing would be a tachypnea, desaturation, cyanosis, not when crying, even not when crying, agitated, limited ability to talk, increased work of breathing, use of accessory muscles, intercostal, subcostal, or suprasternal recession, abdominal breathing. So what else? Nasal flare, head bob, entracheal tug, and forward posture. Okay, so these are signs of increased work of breathing. As for the efficacy of ventilation, we should check it, effect on other organ systems, heart rate, consciousness state. Okay, so how do we assess the efficacy of ventilation? We can check the respiratory noises, wheezes, grunting, crepitations, reduced chest expansion, reduced air entry, secondary signs of inadequate oxygenation such as tachy or bradycardia, color change, pale or blue, cool peripheries, altered mental state. Okay, so all these signs, they can assess the breathing. Now as for management, if the child is not breathing, commence artificial ventilation. Consider elevating head of the bed, oxygen 15 liters per minute, not breather mask, non-invasive ventilation. We start with high flow nasal cannula, CPAP or BiPAP. Do not use self-inflating bags in spontaneously ventilated patients. They're ventilating spontaneously. No, we don't use self-inflating bags. They are designed to deliver oxygen only if squeezed. We can also do emergency airway management. TPs, Neopuff may be used to administer PEEP. If you want more details of emergency airway management, please comment below and I'll discuss it in another video. Okay, now we'll move on to C, which is C for circulation. What do? We check the efficacy of circulation, heart rate, blood pressure, capillary refill, and capillary refill time. So what are the signs? Again, for a distressed circulation or a poor circulation, we've got tachycardia or bradycardia, arrhythmia, narrow pulse pressure, hypotension. Hypotension is a late and pre-terminal sign, okay? So we shouldn't wait until hypotension occurs. We should ensure the correct cuff size, because children, it's not the same as in adults. Delayed capillary refill, flash capillary refill, poor peripheral perfusion, reduced pulse volume. So these are the primary signs. The secondary signs are tachypnea, especially if no increased work of breathing, or bradypnea, altered conscious state, color change, pallor, or cyanosis. So we've got tachypnea or bradypnea, and altered conscious state and color change. These are like later signs. Okay, so what about management? If there are no signs of circulation, no pulse, slow pulse below 60, or you are not sure, commence external cardiac compressions. This is important. So if you're not sure, or no signs of circulation, no pulse, slow pulse, we commence external cardiac compressions. Determine cardiac rhythm and treat accordingly. 2 large bore intravenous cannulas should be inserted, and interosseous cannula if unable to gain IV promptly. So we should do that immediately. Fluid resuscitation, fluid boluses, 10 to 20 milliliters per kg, sodium chloride, NaCl 0.9% up to 40 ml per kg. Consider sepsis, and consider inotropes or vasopressors, and correct electrolytes. Now we move on to disability. We assess altered conscious state through the AVPU, or the GCS, which is the Glasgow Coma Scale, and the AVPU is the Alert Verbal Pain Unresponsive System. If you need any further explanation, please comment below so I can make another video about them. So, what are the clinical features? We've got irritable, lethargic, abnormal AVPU or Glasgow Coma Scales, pupil reflexes, focal motor deficit, seizure activity, and toxin exposure. What do? Management. Blood gas, capillary, venous, and arterial. We should measure blood gases, okay? Hypoglycemia. Check for hypoglycemia. Also perform bedside ketone for hyperketonemia. Hypo or hypernatremia. So we check electrolytes, and hypocalcemia. We should consider brain injury, such as stroke, meningitis or encephalitis, shunt complications, and manage seizures. So that is for disability. Now, lastly, we go to E, which is exposure. We assess the child fully, and temperature. We check for hypo or hyperthermia, rash, petechiae, purpura. We correct the hypothermia and manage the pain. So that's the ABCDE management. Now, there are some important considerations that we should keep in mind. Cardiac dysfunction and pericardial effusion. If that's the case, we should consider a transthoracic echocardiogram. We should consider coagulopathy and non-accidental injury. Now, as for the post-resuscitation care, we refer to and obtain phone advice early from local specialized pediatric service. Review history and examine thoroughly. Reassess regularly to monitor progress. Maintain oxygenation and ventilation. Aim normal systolic blood pressure, urine output, glucose, electrolytes, and temperature. Monitor for end organ damage. Consider analgesia and sedation. Counsel family regularly. So family members of patients undergoing resuscitation should be given the option to be present, ideally with an assigned support person. Regardless of the outcome, resuscitation is stressful and can be psychologically traumatic to team members providing care. Debriefing should be offered to all involved staff who wish to attend. So when do we consider consultation with local pediatric team? When any child requiring resuscitation. So any child requiring resuscitation, we should go for consultation. And we consider transfer when a child is requiring care beyond the comfort level of the hospital. So thank you so much for watching. Please subscribe. And if you have any comments, please leave them below. And if you have any topics you want covered in future videos, please leave a comment below. Thank you so much.